Okay. Shall I start?
Yes, you can start. Yes.
Good afternoon, all the attendees and dear participants. Myself, Duna Shaha. I welcome you all in our today's program of Webinar Super League WSL on behalf of Exrx India. I would like to thank Sri Samraj Physiotherapy Center for arranging this one, together with Peak Health Studio Chennai, Sri Sairam Academy Chennai, Physioactive Gurugram, and I would like to say that we are relaying our today's program in our Fitness and Rehab India YouTube channel. I would like to also welcome our today's volunteer, Prachi Booch, and I would like to welcome our front face and as well the backbone of this program, Dr. Chandra Mohan. And of course, I would like to welcome our today's resource person, Dr. Parth Trivedi. He is MPT Ortho and Sports. He is also a PhD scholar, currently working as a lecturer in CM Patil College of Physiotherapy, Gandhinagar, Gujarat. He is a freelance peer reviewer, Enago Publications academic editor. He is Asian Journal of Orthopedic Research reviewer and Journal of Harmonized Sciences. He is going to explain to you all on our today's topic, understanding lateral epicondylalgia. Sir, please start the session.
Very good evening to all, Dr. Dona. Thanks for a wonderful introduction, Dr. Chandra Mohan and team. As the webinar Super League, this webinar information says that it is all about lateral epicondylalgia, and so called it is tennis elbow. Now, just before starting with the presentation, which is all about what is lateral epicondylalgia, I usually have a tendency to start my sessions with any interesting motivational videos. I would like to go with this video, and it has nothing much more relation with the current topic, but I generally have a tendency. I hope you can see my VLC clear in this. Okay.
Yes, sir, it is visible.
Yes. Uh, yes. So the reason why I had selected this video is this: it is lateral epicondylgia, or you term it as your tennis elbow, or you term it as your uh, lateral epicondylitis. Yes, all of them are your sports injuries, and majority of them occurs because of repeated overuse or improper biomechanics. uh, Through the video, the role which his father played, that is the role which we as a practitioner play in treating this kind of sports injuries. I don't say that this occurs only in sports people or in athletes. It has a majority of percentage. It occurs into the sports or athletes, but it has a few proportion involved into local population, or what we say into general population also. Yes. So what we are going through this is understanding whether we term it as tennis elbow, whether we term it as lateral epicondylitis, or whether it term it as epicondylgia. Yes. So immediately when I had this webinar and the flyers were on, there were few people who had messaged me up that why you have mentioned it lateral epicondylgia, why you have not mentioned it lateral epicondylitis. Yes, or why you have not mentioned a tennis elbow. You can see my slide template also, which is predominantly showing that it is a tennis. But I've mentioned it as a lateral epicondylgia. Yes. So we in this present or in this session, we are going to discuss about two major things. One is the pathophysiology, why what happens in this, and second is the treatment approaches. And those treatment approaches are strictly based on the evidence. Yes. So moving forward with it, I would just like to show that why we have discussing about tennis elbow in is huge. Yes, what is the reason for discussing tennis elbow in such a serious manner, or probably in concerned manner? Yes. So you can see we have our own Sachin Tendulkar, where he has mentioned that he thought at a point of time that his career was over because of tennis elbow. Yes. So at a point of time, I think, if I'm not wrong, it was in 2001 and 2002 during his series. During these 2 years, he was in such a tremendous pain that he was not able to lift his own bat. Yes. And then after, through surgery and through tremendous rehab and uh, technique modifications, he was back into the field. So this is what happens to an athlete when an injury strikes suddenly. We have one of our so-called Bollywood actress, Urvashi Dolakia. She was recently diagnosed with tennis elbow because of extreme use of mobile phone. Yes, so this is what we see generally. Uh, when it comes to tennis elbow, we always think that it is the backhand stroke, or probably it is because of your repeated wrenching movements of the wrist. Even the cell phones are now, repeated use in our day-to-day life are causing this tennis elbow. And this one is the baseball player Tom Brady, and he was also been affected with tennis elbow. So globally, so this is, if you can see, this is 2019 December. So it is just recently he was diagnosed with tennis elbow. So concern over here is what is the optimum treatment, first thing, and second thing, how are we going to term it, whether we are going to term it as tennis elbow, whether we are going to term it as epicondylitis, or whether we're going to term it as epicondylgia. So I would like to get the first poll done. Dr. Duna, I if you can help me out with the first poll question.
Sir, can you hear me?
Yes, yes, yes.
Sir, with the polls, all the questions will be available at once.
Okay, then we can have it as of right now only.
Yeah, we can have it.
Yes, yes. So
Should I launch it?
Yes, yes, yes.
Okay, I am launching the polls.
So to all the participants, we are launching with the polls. The first question
is the poll available?
Yes, yes, yes. The first question is it epicondylitis or epicondylgia? So please select whatever you want. Please don't select based on the topic title. Yes, please select what you are aware about it. Second question is only wrist extension causes LE, lateral epicondylitis, epicondylgia, and is therapeutic ultrasound effective in LE? So whatever you want, you can select it. I am not going to opt it for this poll. You can opt it out. You can opt in for this poll. I am opting out from this poll. Please, I hope the polling is done.
The polling is going on, sir.
Okay. Please let me know.
49 attendants already answered. We have 92 now.
Yes.
Who are attending. 68% already voted. %70 voted already. Still a few left.
I request all the participants to
please take part.
Yes, please take part and answer whatever you are aware about it. Please forget about, we are not going to score you on this basis.
"74 people completed answering.
We'll just wait somewhere around 2 more minutes for this and then we'll move ahead.
Okay, sir. Participants who are joining now, even they can take part in this voting.
Yes.
We have 97 participants here in poll.
99.
97, sir, in poll.
I can see 99. Okay.
Yeah.
97 is done?
No, sir, 77 has completed. We have here in poll 97 participants.
Okay. So we'll move ahead with this. I think majority of them have.
Sir, if you wish, we can continue for 30 or 40 seconds.
Okay.
More.
Okay.
Fine, sir. 80 of 90, 100 participants have polled it.
Great. So we'll move ahead with it then.
Yes, sir.
I think somebody is scribbling the. Yes. Please help me out with the annotation because while the presentation, I think there are unintentionally the annotation is being used by somebody. Anyways, we'll move ahead with this. So the reason why we are much more focusing with the this kinds of orthopedic or sports related condition is because majority of these conditions occurs into athlete. Oh great, great. So we have the sharing results. So majority of them, 73% have told me that it is epicondylitis. Second question, only wrist extension causes LE. 23% have said yes and 78 have no. And is therapeutic ultrasound effective in LE? 91% and 9% have said no. Great. So yes, with this we would be considering the polls and we would discuss all these three major questions in our presentation. So yes. So whenever this kinds of injury occurs to an athlete, the concern is the athlete is out of the game. And the athlete in today's world is under so much tremendous pressure to come back on field and prove that nobody can take his place. So once the athlete is out of the field, yes, that person is in that tremendous pressure that if is prolonged period of time he is out of the field, somebody else will take that place and the career is over. And injuries don't come and knock your doors that may I come in. Injuries come suddenly. Yes. So our role as therapist is to focus on best available evidence-based treatment rather than what we know or rather than what the world is doing. Yes. Currently, we have a globalized scenario of COVID-19. Yes, some one odd day, I would not like to name out the company's name. We had somewhere again 2 days or 3 days back, a company had a huge press conference and had claimed the efficacy of its medicine in treating coronavirus. And immediately after 2 3 hours our government reacted it, and we the company was being told that you prove that whether it is effective or not. So this is what we are currently focusing on, that how are we going to treat this condition and what is the pathophysiology of this. So moving ahead with this, yes, what are we going to see? We are just going to concern about definition and characteristics of the lateral epicondylitis, epicondylgia, tennis elbow. Yes, anatomy, pathophysiology, signs and symptoms, diagnosis, and management. So this will be our presentation flow, and gradually we will move on with this. So general term definition, as I said, we had seen in our previous newspaper cutouts also. Yes, majority of them term it out as tennis elbow. Yes, and why? Because it was the term which was being first used by Runge in 1873. So it is not a new phenomena. Since 1873, we are into this term known as tennis elbow. Yes, I have used the heading general term. Yes, so definition, this is in general terms and this is in majority of terms. Okay, now generally what we say that tennis elbow is a condition which affects the lateral epicondyle or the common extensor group of muscles. And the extensor group of muscles, what they do is they extend the wrist. So when you are repeatedly using this wrist extension movement, you have a tendency of injuring these common extensor group of muscles, and basically it is extensor carpi radialis brevis. The most commonest muscle is extensor carpi radialis brevis. Okay, so here what we have two basic one is lateral epicondyle of the humerus. Definitely, we are considering humerus here, and another is medial epicondyle. Yes, this lateral epicondyle we have common extensors of wrist origin. Yes, and over the medial epicondyle we have common flexor group of muscle of wrist origin. So these two are basically the origin point of two different group of muscles. One is common extensors, another is common flexors. This common extensors, an injury to this is known as lateral epicondyle. I will term it as epicondylgia currently because I have my own title over this, and this is known as medial epicondylitis. Okay, so you would one currently who are actively participating in this presentation should have a question why I have mentioned it as epicondylgia over here, and why I have mentioned here as epicondylitis. Okay, so you have all the rights to question me and prove me wrong. Okay, so let us go to my slide again. So briefly coming out that the term was first described in 1873 by Runch. It is tennis elbow. Yes, there is no doubt about it. Why it was tennis elbow? Because during that period of time, it was more seen in tennis players. Okay, and to your surprise, you would, if you see the athletic injuries now, you would see very less people affecting by this condition in tennis now because of advanced biomechanical analysis and advanced rehab. Yes, so this is the reason why now this injury is now gradually decreasing into the athletic population, and it is now much more into our general population. And the general definition is an injury occurring to the lateral epicondyle region, okay, lateral epicondyle region of the humerus, and pain over that region is known as lateral epicondylitis. Okay, so basically the definition can be divided into three major parts. One is structurally affected, which kind of structures are affected. Second is which kind of activity restriction is there. And third is what kind of participation restriction is there. Now, why I have mentioned it about structures and uh, participation and activity. The reason is because of ICF, International Classification of Disease. Yes. So when you term this, or in previous version, it was known as ICIDH. Okay. So when you are talking about anything, or when you are presenting about anything, you just cannot say that this is A or this is B. We need to have an international classification code, and that is why I have currently divided the definition into three basic parts, international, on the basis of international classification of disease. In this particularly, three major things are being concerned. One is structure which is affected, another the activity which is restricted, and another is participation which is restricted. So based on these three phenomena, we have this international classification. Yes. So what kind of structures are being affected in this? The structure which are affected in this is basically extensor tendon. As I said, common extensor tendons are affected of the forearm, and you have seen a gradually decrease in degeneration of collagen, and additionally it might be affected by composition of neural drive and stiffness of muscle tendon complex. So when you have an injury progressing, gradually progressing into a chronic stage from acute, you see that muscle fiber compositions like collagen fibers decreases, and it has been increased by fibroblast. So this muscle fiber composition gets involved. You have nociceptors coming into picture, and then you have restricted range of motions in elbow also and in wrist also, causing it this kind of definition based on structure which is affected. Now, based on activity which is affected. So basically, as I said, it is your wrist extension movement which gets affected. Additionally, you have inabilities in gripping, inabilities in holding things. Yes, if I want to hold my cell phone also, this causes pain. This causes pain in chronic cases and in severe cases. So this basically is the activity which gets affected. It is performing excessive, quick, repetitive activities like gripping or manipulating objects, manipulating like you are using it. Yeah, you are, you're wrenching your cloths. Yes, that kind of activity causes pain over lateral epicondyle region, which can be radiated over the forearm aspect. So that is the major activity which gets involved. And what are the participation restrictions? Once this happens, what happens to the individual? What kind of restrictions are there? It is functional impairments like causing difficulty to work. Like if a person is a laborer and he is involved in nailing things, that gets affected. A mechanic, a screwdriver, yes, if that participation is restricted. Sometimes holding a grocery bag is also getting affected. So this ultimately what it causes, it reduces the productivity of an individual. So basically, revising it very quickly, we have, based on the structure, yes, I will say common extensors are involved, activity, wrist, extension and gripping activities are involved, and participation restriction. We have in numbers of participation and reducing the productivity. Okay, so these are the basic takeaway points from our definition section, that once a patient or once an individual gets affected with lateral epicondylitis, I have seen individuals taking it very lightly, and I have seen uh, you know individuals getting treatment. One of the most commonest treatment is our steroid injections immediately, and then they later come up with severe pain. So I'll discuss the management part gradually once we move on with this. So briefly discussing about the anatomy of the elbow joint, we are not much discussing about the anatomy of wrist joint. Why? Because the insertion part is there into the wrist joint. We are much more concerned over the origin of pain. Yes, so that is the reason we are discussing about anatomy of elbow joint. So type of joint, it is a hinge type of joint. So hinge type of joint means you just have 1 degree of freedom, that is your flexion and extension. So these two basic types of movements are available. Bones, you have humerus, radius and ulna get joining together and getting your elbow joint. Yes. Which kinds of ligaments do we have? We have ulnar collateral ligaments, radial collateral ligaments, annular ligaments, and quadrate ligaments. So basically, when an elbow sprain is considered, a very less kind of a percentage of people suffer from the elbow sprain injuries. You have ulnar ligaments and radial ligaments getting into picture. Rather, these annual ligaments and quadrate ligaments are very small. Common muscles. What kind of muscles do we have which either originate or either insert at your elbow joint? We have biceps muscle, which is inserting, triceps muscles, which is inserting, common extensors of wrist, origin, common flexors of wrist, origin, pronator teres, origin, brachioradialis, again insertion, brachialis insertions, and anconis insertion. So basically, these three group of muscles are supinator. I have not mentioned it because of the concern of the topic. So these three group of muscles are basically the origin muscles, yes, and rest of them are insertion muscles. Blood supply. Uh, if we talk about the blood supply, yes, to the elbow joint, we have proximal to the elbow and distal to the elbow. So the proximal to the elbow is ulnar collateral artery, middle collateral artery, radial recurrent artery, and ulnar recurrent artery. Okay, I can see somebody who is, using the annotation apart from me. The above annotations are not from me. So just to avoid, what can I do is I will use the spotlight. Okay. So the blood supply is basically divided into two major sections, proximal to the elbow and distal to the elbow. It is mainly through your ulnar collateral artery, radial collateral artery, and middle collateral artery, and radial recurrent and ulnar recurrent arteries. So as I said, it is a hinge type of joint. We have flexions and extensions, and clinically, we majoritarily see fracture. And which fracture is common? Supracondylar fracture of humerus is much more common when we term it about clinical into the elbow joint. Epicondylitis, you have lateral epicondylitis or lateral epicondylgia, and medial epicondylitis and epicondylgia, and arthritis. So we have very less population coming because of elbow arthritis. Elbow arthritis is not only osteoarthritis. We have rheumatoid arthritis. We can term it out as gout also coming into picture because of this. Okay, so this is what we are. What is our anatomy of elbow joint is considered. So now, what is the role of ECRB and ECRL? When I term it out as ECRB, it is extensor carpi radialis brevis, and ECRL, it is extensor carpi radialis longus. Brevis, a small muscle; longus, larger muscle. So basically, these two muscles are much more into wrist extensor. Yes, and onto these two muscles, you have brachioradialis muscle coming into the picture throughout the forearm. And what these two muscles do? These two muscles basically do pure wrist extensions and radial deviations. Sometimes radial deviation occurs. Okay, so because of this, you have pure wrist extension of ECRB and ECRL, and a radial deviation is the major role of ECRB and ECRL. So why these two muscles work, and why these two are the only muscles which are getting affected? Okay, so we will see. Yes, you can see these two figures. The above one I have mentioned it with good, and the second one, sorry, yes, 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 this is good and this is poor. Now, why I have mentioned it? Okay, so if you see, the movement of force is going on from the shoulder to the elbow and then to the wrist. So here you have minimal extension of wrist, minimal extension of wrist, and the major amount of force, yes, is generated through your larger group of muscles, that is your back muscles and your shoulder girdle muscles, and it has been transferred to your elbow group of muscles, and then you have a wrist extension. So whenever the ball strikes, yes, so there is less counter effect of the ball, yes, causing it to sudden wrist flexion, and you don't have to force the wrist extension much more so that the ball reaches to the opposite pole. Whereas if you see this poor, why I have mentioned it poor, the force which has been generated by a larger group of shoulder girdle muscles, so big muscles, it is transferred to the elbow, and then it has to travel to the wrist much more larger distance, much more longer distance, and then you see the wrist has to extend fully. Wrist has to extend fully, so you have a huge amount of concentric muscle force, huge amount of concentric muscle force coming into the picture. So for example, this is my uh, racket, tennis racket. Yes, I'm just specifically talking about my backhand stroke. This is your backhand stroke. So if this, I've holded this, and if I have the group of muscle force which is traveling from shoulder group and it is traveling to the elbow, so what I'm supposed to do, I'm just supposed to do flicker of contraction. Yes, so the force will be automatically transferred from my shoulder group of muscles to the tennis ball, and the ball will move. So I have to put much more lesser lesser amount of energy for that stroke. Whereas if I am having an extended elbow and then I am supposed to give a backhand stroke, more force will be generated from the lateral epicondyle, which is your wrist extensors. And then what will happen, if the ball will always give a counter reaction force and you have an eccentric contraction following. So immediately after your concentric contraction, you have an eccentric contraction, and much more compared to your concentric contraction, your eccentric contraction, yes, eccentric contraction of ECRB is responsible for this. Yes, so you have two types of muscle contractions when we term it about your isotonic contractions. You have concentric contractions and eccentric contraction. In concentric contraction, what happens? You have the insertion group of muscle, insertion of the muscle moving towards the origin of the muscle, and in eccentric contraction, you have the insertion of the muscle moving towards or moving away from the origin. So in this, you can see the much more wrist extension forces needed, or that is being given by your wrist group of muscle. Here the transformation of the force will occur, and here more force will be required by wrist, okay, to get the work done. So this is what I hope the things are clear. We can discuss it later on in the question answer sections. So yes, moving on towards the pathophysiology. Yes, so I have mentioned clearly traditional view. Yes, so in 1936, as we all know, in 1873, tennis elbow was the term which was being coined by Runge. Okay, so in 1973, Dr. J. Cyriax, yes, so you would have heard about Cyriax manipulation or Cyriax deep friction massage. The same person had termed that repeated contractions, sorry, repeated contractions of wrist extensor group of muscles, basically your ECRB and ECRL, that leads to your macroscopic and microscopic tear. Okay, and this is because of your chronic overuse. Chronic overuse means repeated wrist extension causes macroscopic and microscopic tears. Okay, as these tears attempt to unite, what happens? It leads to inflammation. So once there is a tear, yes, once there is a tear, these definitely body will try to heal itself, and this healing procedure will cause inflammation, and that is the reason where we as a therapist or probably the treatment managers, okay, we consider over anti-inflammation properties. So that is the reason anti-inflammatory model of rehabilitation is used when we term it about, especially about NSAIDs or our therapeutic modalities like ultrasound. Yes, okay, so these two basic things work upon our own anti-inflammatory models. Yes, so that is the reason we are using anti-inflammatory. So now, to how extent it is right. Okay, so let us discuss about why it is tendinosis. So before I request the participants, please don't use this annotations, you know. Before we move on towards the tendinosis cycle, I would like to show you one more video so that you know you are definitely not getting bored with my presentation. So this is
Excuse me,
what we
sir.
were discussing. So this is what we were discussing. Yes, the
Can
backhand
you
stroke.
find the stop annotation option?
Okay.
Excuse me, sir.
Yeah, just wait a minute, Dr. Dona. Yes.
Can you see the stop annotation option?
Actually, it is there into our. If you go www.zoom.us, you need to sign in, and
No,
then you need to
stop
stop it.
annotation option is available with you, sir, because you are sharing your screen.
Uh, okay, I'll check it out later on.
Yes, sir. Yes. Okay.
Yes. So this is what we have discussed in our previous pictorial presentation also. So basically what happens, you are continuously using your wrist extensor group of muscles, and this wrist extensor group of muscles gets into macro and microscopic tears, and then it leads to inflammation, and because of inflammation we have termed it out as lateral epicondylitis. Now till this period we were just thinking that, we are just, if you just imagine this is a movie which is going on, and there was one hero which is lateral epicondylitis. Yes, so we are just thinking that lateral epicondylitis is our hero till this moment, and we have done the polling also. Yes, so majority of us, we think that lateral epicondylitis is our hero. But uh, my dear participants, sequential studies, which are later performed from 1970s, they have termed it out that the failed reparative process of main extensor carpi radialis brevis tendon is the main reason for pain and disability. Yes, so there were studies based on the cadavers and even the patients who had undergone with lateral tennis elbow. They found that there are no inflammatory markers into the study, into the patients or into ECRB muscles. So there are no more inflammatory markers are not available, but the repetitive injury is causing trouble to ECRB muscle, and that ECRB muscle, because of repetitive use, is failing to regenerate. And once it is failing to regenerate because of normal collagen synthesis, the fibroblast come into picture. Now these collagen and fibroblast are like identical brothers. The collagen has much more elasticity and much more tensile stress compared to your fibroblast. This collagen, because of repetitive injury, these collagen are replaced by fibroblast, and fibroblasts are lesser elastic components and having lesser tensile stress. So if you are aware about a stress strain curve, the stress strain curve goes like this. Okay, where it is the optimum stress period and this is your healing period. Yes, so this stress strain, based on the stress strain curves, your collagen are much more having much more elastic property and having much more tensile stress compared to your fibroblast. And this is proved by Dr. R. Nischel in 1970 that there is a dense population of fibroblasts and immature collagen, and he termed this as angiofibroblastic hyperplasia. Hyperplasia means the count of fibroblast has increased in ECRP muscles. So it is not the inflammation. It is not the inflammation. It is angiofibroblastic hyperplasia, which is the main culprit of this injury. So it would not be right to term epicondylitis, it would be the right to term epicondylgia. Okay, you'll get clear picture with this. Then the question comes, yes, majority of you would ask me, sir, then why it is epicondylitis everywhere? Epicondylitis, even the orthopedic practitioners write, even you have seen many textbooks, even the older version of clinical orthopedic rehabilitation by S. Broadsman termed it out as epicondylitis. It is just because of popularity and inherent simplicity. We are terming it out as epicondylitis. Okay, because of its inherent simplicity and remained entrenched, we are terming it out about it epicondylitis. I think majority of you would question me later on that, you know, I am contradicting, but this is what numerous studies have focused on, and a good number of meta analysis have said that epicondylitis needs to be replaced by epicondylgia. The question was goes to first, then why we are terming it out as medial epicondylitis? Yes, till this point, till this presentation, there are no studies or less number of studies supporting the medial epicondylgia. Okay, specific studies are done on lateral epicondylitis and lateral epicondylgia. There is no much more strong proof evidence saying it is medial epicondylgia. So that is the reason I had mentioned medial epicondylitis there, and I am continuously repeatedly saying it is epicondylgia. Why it is epicondylgia? Because inflammatory markers are not there, and you have a angiofibroblastic hyperplasia being replaced. Okay, so that is the reason it is epicondylgia. So then what is the cause of pain? Okay, so if it is not inflammation, what is the cause of pain? The cause of pain is your irritants, biochemical irritants, your lactic acid and chondroitin sulfate. These two basic things act as your pain causing substances. So that is the reason we are getting pain. Okay. So basically, if you talk about the pain component and the disability component, you have three main components coming into picture. One is your tendon pathology, which we have discussed, angiofibroblastic hyperplasia. That is the reason which is causing pain. Second comes your neurogenic composition. Yes. So mechanical stimulations of the nociceptors. So continuous using of wrist extensors, your nociceptors. Nociceptors are first order of pain. Yes. Sensitors. So these pain sensitors get actually activated because of repetitive movements, and those nociceptors of ECRB tendon release your precipitates and causes vasodilation and plasma extravasation, causing it as neurogenic inflammation. Okay, so this is the reason where you have neurogenic component coming into picture. So we have discussed for what reasons pain is there. First reason is your tendon pathology. Tendon pathology, angiofibroblastic hyperplasia. Second reason is your nociceptors. Why? Because of neurogenic inflammation. And third one is your decrease in muscle strength. Decrease in muscle strength because of mucopolysaccharide infiltration. Mucopolysaccharide infiltration. So actually, as they term it out as saccharides, saccharides are nothing but a glucose chain. So muco means mucus and polysaccharide. So mucus and polysaccharide, n numbers of polysaccharide glucose chain are being found into ECRB muscles. Very miniature bone formation occurs. Yes, vascular proliferation is there, and immature fibroblasts are there. So because of all these reasons, the muscle strength decreases. So this is known as three model pain component stimulus. So this is, I would like to show you in an article. Yes. So this is what it is known as pathophysiology. So it is an interactive component, yes, into pathophysiology, local tendon pathophysiology, pain system, and motor system impairment. So these three components are there into the reason it is known as tendinosis. So one may ask why it is only ECRP, why it is not ECRL, or why it is not any other extensor RP ulnar is coming into picture. First thing, it has compromised blood supply. Yes. So because of neovascularization, yes, you have lesser blood supply. So that is why inconsistent vascular pattern and compromised blood supply, ECRP is much more involved. Whenever you have an eccentric activity, wrist flexion, your ECRP will get strained much more, and in the limited internal rotation. So if my the shoulder is much more internal rotated, if you can see me in my video, the force can be transformed easily to my elbows and to the wrist. So if I have much more external rotation, it becomes difficult to transfer my force to the wrist. So that is the reason. So if much more external rotation is there, we have much more stress, tensile stress over ECRB group of muscle. Yes, so that is the reason the ECRB is much more involved into this. Few people have complaints of pain while pronation. While pronation. So why pronation? Because radial head ECRB is functioning over the radial head also, yes, and it causes extension of wrist based on radial head rotation. Yes, so that is the reason ECRB muscle, when it is being stressed out, it causes pain over pronating activity also. So basically, wrist extension and pronation, these two things cause pain over the regions. And what are the other structures? Without much wasting time, we have local articular ligaments, nerve lesions, and cervical fine structures getting into picture. So you have differential diagnosis. I will see it. So yes, this is the tendinosis cycle. Okay. So tendinosis cycle, you have increased demand of a tendon. So once this increased demand of tendon, it is your repeated wrist extension and flexion movements. Okay. So if you give adequate repair, it will adapt. If there is no repair, what will happen? Premature collagen will come. So premature collagen, tenocytes will form, abnormal bones, and the muscle will be reducing into the strength. Further reduction in the collagen, predeposition of further injury, and this cycle goes on. So ultimately, we need to break this cycle to get into adequate repair. So this is why we term it out this as a tendinosis cycle and lateral epicondylalgia, not epicondylitis. So what I have discussed in detail is pathophysiology. The pathophysiology is of three major parts: lack of inflammatory responses, substances into these studies. You have local tendon pathology, angiofibroblastic, pain systems, yes, your nociceptors, yes, lactic acid components, and motor system impairments, reduced collagen fibers, so reduce stress of the muscle. So these three are basically responsible for getting your lateral epicondylgia. What are the classical signs and symptoms? Pain over lateral epicondyle of the humerus, tenderness, decreased grip strength, and localized swelling. So these are the three basic signs and symptoms of this injury. Diagnosis, I'm not going it in detail depth of diagnosis. What does MRI says or what does ultrasonography says? Because if I continue with this, it would take somewhere around 2-3 hours to complete this presentation. So just briefing it out, we have three major tests. If you see this one, this is your Cosen's test. The second one is Mills test, and the third one is your Modley's test. So in Cosen's test, what you are doing, elbow is slightly flexed, Okay, and it is pronated, and you ask the patient or ask the athlete to extend the wrist over your resisted movement. So if it is he is extending the wrist and you are resisting the movement, and if there is pain over lateral epicondyle region over this specific region, it is the positive Cosen's test. Whereas in Mills test, it is extended elbow and you are flexing it. You are flexing it your uh, wrist. So if pain is there, this lateral epicondyle region, it is positive Mills test. And Modley's test, extending the middle finger and asking the patient whether the pain is there or not. This is Modley's test. So what is the difference between Cosen's test and Mills test? Here you are seeing the concentric activity, and here you are seeing the eccentric activity of the muscle. Okay, so sometimes it is possible your Cosen's is negative and your Mills is positive because of the eccentric group of muscle component involved. So it is always better to test at least two tests uh, rather than relying on only one test. Then we have ultrasonography and MRI to confirm. I would just name it out. I will not go in depth analysis of this. Okay. Yes, what are the treatment outcome measures? Okay, so the treatment outcome measures are basically pain. Yes, pain. How are we going to check it out whether the pain? Unlike the temperature, we don't have any equipment which measures pain. Yes, so pain is always subjective and it is a multifactorial component. So you have visual analog scale, you have NPRS and various McGill pain questionnaires there. I will just explain the difference between the visual analog scale and NPRS. The difference between visual analog scale is, uh, if you can see my scale, this is horizontal visual analog scale. On to the left, it is 0. On to the right, it is 10. So if I term it 0 means minimum pain and 10 means maximum pain, the subject or the patient is supposed to put a line over this. So for example, I put a line over this. There is no number. So it is assumed that pain is somewhere between 3 and 4. Okay. So there are no numbers. So sometimes you can write no pain and or minimal pain, and on to right you can write maximum pain. Yes, so there are no numbers, so that is why it is visual analog scale. And in NPRS scale, yes, uh, this is again a horizontal scale. You have yes, 0, 1, 2, 3 and so on till 10. So you have numbers in this, and if once you are asking it what kind of pain is there, if the patient says this, it is obviously 3. So this is the basic difference between visual analog scale and numerical pain rating scale. I always prefer that we should move on to NPRS because of its reliability and validity compared to VAS. But still majority of people are using visual analog scale. Then hand grip strength, it is your hand dynamometer. We are seeing it in later as an image. Functional performance, patient rated tennis elbow evaluation, PRTE. Again, I will be showing it how we are scoring it. Uh, Dash dynamic arm shoulder scale, shoulder and hand scale. This is again a scale, and muscle activity is through surface EMG. I will show you one of the video also later on how we can see the surface EMG and how we can use it in virtual rehab. So yes, this is your hand dynamometer. So if you can see over here, first line, second line, third line, fourth line, and fifth line. Sorry, this is your first, second, third, fourth, and fifth grip. So currently the hand dynamometer is on to the third level. So as per as studies are considered, an American Society of Hand Therapists, ASHT, they recommend that the hand dynamometer should be used in the third position, yes, and three trials should be given. So here you can see the numbers onto the outer ring and numbers onto the inner ring. See, outer ring numbers are usually in pounds and inner ring numbers are usually in kgs. So in India, we generally prefer kgs, and in Western countries, the readings are generally preferred in pounds. But when you term it about international standards, pound is much more preferred value, and for getting the ratings done. So what are we supposed to do it while taking the ratings? First thing, you are supposed to ask the patient to sit erect in an unsupported armchair. There should not be armrest, and ask the patient to do 90 degrees of elbow flexion. You are asking the patient and giving the hand dynamometer in the hand, and then asking the patient to squeeze as much as possible. So once the squeezing is done, this reading will go up. Okay, so like this, you are supposed to take 3 readings, and average of that 3 readings is considered as your grip strength. Okay, moving on with the patient rated tennis elbow evaluation. This tennis elbow evaluation has 2 major components. First, it was known as PRFETQ, and now it is known as PRTEE. It is pain score is there. Yes, pain score is there, and function score is there. In pain, you have 5 pain items, and in function, you have 10 pain items. So best score is again 0, and worst score is again 50. We are not moving on how to read this scale, but I'm just giving you a brief idea about this. So what are the pain questions? When you are rest, are you having pain? So if yes, rated 2. When you are doing a task, 8. When you are carrying plastic bag, 7. When you are at your palm is at least, what is the pain? And when you are at worst, 9 pain. So you can here you can see that various components of pain, how the pain is there, at what time the pain is there, and when is the maximum pain is there. So this is what it has been, this domain concerns. So what you are supposed to do is, you are supposed to do the totaling and divide it by 50. So here you'll get a total, and specific activities, they are again divided into 2. One is the activities are again divided into 2: specific activities and usual activities. So like if you are turning the doorknob, if you're carrying the grocery bags, if you're opening the jar, pulling up the pants, you are washing it out, wash towels or wet. So what kind of in difficulties you are facing it out? Please see, this is not pain, this is difficulty. Okay, and usual activities like dressing, washing, household activities, work activities. So you are supposed to rate it out about 10. So please make sure that all these readings are rated by patient himself and not by the therapist. Okay, so ultimately what you are getting it done, you are getting the scores done. So 31 was your pain score and 14 was your functional score. So what is your score? 45 out of 100. More the score, more the disability, and lesser the score, lesser the disability and pain. So this is what your hand evaluation matters. So nowadays, to all the listeners, whenever you are taking an assessment, please make sure that you are following SOAP format, subjective objective assessment and planning format. And in assessment, you are not only measuring pain, you are measuring the functional capacities also, okay, through various questionnaires. So this basically proves that you are putting an evidence for treating a patient. Okay, and you would definitely you would require to review it later on. So this is the differential diagnosis. Okay, lateral epicondylitis, intra-articular pathology, cervical radiculopathy, lateral. This is again from your S. Brotsman. Okay, so well localized pain, tender, generalized elbow pain, diffuse lateral arm, vague. So these are what your differential diagnosis is. So generally, lateral epicondylalgia, if you rule it out from cervical spine pathology, I generally what I do is to rule out if the patient says he is having a bit radiating pain over the forearm component only. I generally do cervical pain test like Sperling test or the compression test to rule out whether the cervical spine is involved or not. Okay, So this is what I generally do. Yes. So now we are talking it about management. Okay, I think we have crossed 1 hour 10 minutes. So quickly revising. I hope Dr. Duna and Dr. Chandramohan, there is no issues with the time limits.
No
No, sir,
issues,
you
sir.
can
No issues.
continue,
No
sir.
issues. You can continue.
Okay. Uh, so the I am not going to talk what is there into the books or what people say. I personally believe I need evidence and I need systematic evidence. I just don't need a case report to prove that this treatment is effective. Yes. So why I have stated non-steroidal anti-inflammatory drugs, because all the evidences currently say this, that you are supposed to use NSAIDs, and majority of the prescriptions they have NSAIDs. So that is why I have mentioned about NSAIDs, corticosteroid injections. I think this would be new to all of you. Topical glyceryl trinitrate patches are used. Then we are thinking it about exercise therapy, manual therapy, taping, ultrasound, and extracorporeal shockwave therapy, laser, orthotics, acupuncture, PRP injections. These are coming into nowadays. I have seen many orthopedic practitioners and even the patients taking these platelet-rich plasma injections. Again, hyaluron gel injections and botulinum toxin injections are also available, and surgery. So each and every will be treatment. I'm not going to discuss how it is given. I am going to discuss what is the evidence and how we are going to put into our management. Okay. Yes, non-steroidal anti-inflammatory drugs. Definitely, it reduces the inflammation. It causes reduction in the pain. But studies say that there is no long-term efficacy. So once you are being treated with NSAIDs, there are chances of recurrence, and always you have a side effects of gastrointestinal bleedings, GI complications, and renal impairments. And at a point, tendon healing is risked because of inflammation. Because of inflammation, there is no granulation tissue formation, collagen fibers are restricted, and tendon repair is restricted. So again, that tendinosis cycle which we had discussed, we cannot break that cycle. So NSAIDs, not more long-term efficacy is not seen. Yes, definitely it is effective in acute cases and subacute cases, and immediate effect has been given through NSAIDs. Okay, but topical NSAIDs, yes, if you talk about topical NSAID like pain relief sprays, diclofenac sprays or aceclofenac sprays, which are available into the markets, small studies say that it gives effects up to 4 weeks. Okay, so again, if you want, we can use topical NSAIDs rather than your tablet forms. Okay, for pain reliefs. Corticosteroid injections, one of the most commonest practice in treating this condition is corticosteroid injections. I have personally seen, the reason why I'm discussing this topic in much depth is because in my masters I had this topic as my research. My PhD is on this topic, and I have somewhere around 8 to 9 publications, international publications, in this topic. So this is my area of interest, and I have seen somewhere around not less than 200 patients, not less than 200 patients for tennis elbow or lateral epicondylitis during this tenure of somewhere around 7 to 8 years. These patients, yes, immediate result is corticosteroid injections. Okay, so very in short term, yes, corticosteroid injections give short term pain relief, but the patients who have undergone corticosteroid injections in somewhere between 6 to 8 weeks come back with the same pain, and the pain intensity has increased in this patient group of patients. So this is clearly seen into large group of trials, and they say that 72% of patients treated with steroid injection experience recurrence within 12 months. That is just in a year. Yes, this is what study says, but I have seen somewhere around 12 weeks or some 12 to 16 weeks duration of time. So that is somewhere around 3 months or 2 to 3 months. These patients come back with us and say that the pain has increased. Okay, so this is what it is highly discouraged, and I don't recommend my patients or my even to you that we should not recommend corticosteroid injections. To some people it would hurt, yes, but this is not recommended or based on evidence. TGN, topical glyceryl trinitrate patches. Okay, it has shown effect on tendon healing, but one of the most commonest side effect is headache, dizziness, and irritation. Okay, very less population people and very less practitioners use this kind of patches for pain relief. So that is why I've mentioned that in 2011, McCallum did a study with somewhere around 58 patients, very less group of people. 58 is nothing. Yes, 6 patients, 6 months of topical GTN and placebo effect and rehabilitation. But 5 years after discontinuation of therapy, there was no difference in pain and hand grip strength. So there is no much more significant evidence for TGN. Okay, and it has no additional long-term benefits. So you may see that NSAIDs are not working, corticosteroids are not working, TGN is not working. Yes, uh, till this date, treating this condition, I would give you an example. Somewhere around 20 days back, just before starting of this month, I had received a call from one of the leading orthopedic practitioner from Ahmedabad. The patient was of somewhere around 35 years old, male patient. 2 years back, long-standing history of chronic tennis elbow. Patient first time when he had tennis elbow, he had underwent corticosteroid injections, and after 4 months, the pain increased. And what was his injury? Why the injury was causing pain? It was because he had one dog, and the dog had hip hyperplasia, so the dog was not able to move. So while taking care of dog, he used to this kind of movements, so that was causing pain. So later on, he met with another orthopedic surgeon in Ahmedabad. He gave again corticosteroid injections, but there was no effect in that patient. So he changed the third orthopedic surgeon. That third orthopedic surgeon again prescribed NSAID. There was no much difference. Then the patient was given PRP and dextrose injections. The pain reduced by somewhere around 30 to 40%. And the patient was then referred to me by that practitioner, stating it out that I should look after that patient and the treatment should be given. So till 1.5 years or probably quarter to 2 years, the patient had not underwent physiotherapy treatment. Okay, so I'll, I'll later on say what I had given. Okay, I'll keep a suspense over this. Exercise therapy, yes, good evidence says that your exercise therapy like strengthening exercises and stretching exercises are helpful. Why? Because the tendon remodeling occurs and your muscles has an adaptive responses. So isokinetic, isometric, isotonic, and plyometric exercises are helpful. So generally what I do is, and based on the analysis, meta-analysis and evidence base, we generally start with isometric contractions first. Yes, then we move to isotonic contractions, and then isokinetic if available. Yes, if not available, we jump to plyometric exercises. Why plyometric exercise? This plyometric exercises are used to train the athlete. Yes, because plyometric exercises has stress, strain, okay, and in short duration of time. So we are basically focusing on stress and strain cycle of a muscle, and we are putting elongating the muscle and shortening the muscle in very short duration of time. This helps us out in recurrence of the injury. So majority of the cases, if you see evidence, chronic cases come back again and again, again and again. So in one of my study, I've done one of my study. It is under publication, so I would not disclose the data about it. But we have found that somewhere around 70% of people who are being administered with plyometric exercises have a positive outcome, and that group is like 150 patients we have taken, 150 samples we have taken. So let's hope that it gets published and I can share with you all. Uh, so recent meta-analysis have shown that stretching plus strengthening exercises gives better results compared to ultrasound and friction. Manual therapy, deep transfer friction massage, which has been advocated by CDX. It acts again your pain mechanism, inhibiting pain mechanism. Cochrane review says it is not much effective. Okay, it is not much effective when combined with other physiotherapy modalities also. Okay, so was no better than physiotherapy alone. So if you think that if we are just using stretching and strengthening exercises also, there is no need of deep transfer friction massage, which has any significant improvements. Yes, then we have Mulligan's manual mobilizations. Yes, this Mulligan's manual mobilization has proved uh, into systemic trials and systemic reviews that it has in moderate to high quality, that it is much more effective combined, sorry, when compared to your deep transfer friction and placebo. So I again advocate that stretching, strengthening, plyometric exercises, Mulligan's we can use definitely. Soft tissue release, MFR. So MFR is again focused on giving long stretch and much more load and long stretches to specific fascia components. Yes, and releasing the fascia, thereby improving the vascularity and improving the flexibility component of the muscle. So in 2012, an RCT says that it is effective. Yes, definitely it is effective, MFR. So FFR is generally being treated at three levels. One is at your epicondyle level, another is your forearm level, and third is at your wrist insertion levels. So when you give MFR at these three specific levels, you definitely get results. Muscle energy technique, similar, brother and sisters, yes, from different mothers, MET. Muscle energy technique. It is again a soft tissue release technique, a soft tissue pain relief techniques. Here they have two major things: post isometric relaxation and reciprocal inhibition. In post isometric relaxation, what do we generally do? We ask the patient to contract the muscle, isometrically contract the muscle, and then give the relaxation, agonist group of muscle. And in reciprocal inhibition, what we do, we ask the patient to do isometric contraction of the agonist group of muscle, and then we antagonist muscle is being stretched. So basically what you are doing concentric activity and eccentric activity. Larger group of studies are necessary in this segment to prove the efficacy, but in 2013 an RCT was done and it is effective in this. So currently I am also doing a study on effectiveness of MET and MFR in LE. So that is what we are doing it. Again, taping is controversial. I would not like to throw much light on this because we have various kind of taping: kinesio taping, rigid taping, sports taping. Yes, but there are no evidence, and actually US government has stopped or has prohibited taping itself because kinesio taping, because of lack of evidence in supporting the treatment. But I was talking to one of my sports physiotherapist friend, and we were just discussing about taping in athletes. He told that there is one athlete, he's a sports physiotherapist for Mumbai Indians team, IPL team. He told that certain group of athletes have a psychological dependence on taping, and especially with the colors. So there is one athlete, I will not name it out. he prefers one cricketer. He prefers to use only pink color of tape. Yes, when he is treated. So again, lack of evidence of taping is there. So I think it is not appropriate to discuss this also because there is no evidence. Yes, ultrasound therapy. I had a question. We had a question in polling, that is ultrasound effective? Majority of us will say yes. Even I used to say yes, but all these studies say that it is effective in only acute and initial cases. Lunderberg et al. Did a study when it was compared with placebo. The pain of LE patient was better 3 months after such treatment, but there was no much difference in global improvement. Yes. So what does this say is that definitely pain reduction is there through ultrasound therapy, but there is no much more global improvement. So there is no improvement in the muscle strength or recurrence rate of this. So again, ultrasound therapy, we can use it, especially with phonophorosis in treating this condition. Extracorporeal shockwave therapy basically started with lithotripsy. Okay, lithotripsy is generally used for removing stones from kidney. So this is what the basic principle of extracorporeal therapy is. Uh, Calcified deposit are used, and actually US Food and Drug Administrator has only approved for the treatment of plantar fasciitis and LE. Okay, so RCTs have said that it is effective, but a recent RCT in Hong Kong state that 72 patients, it was done on 72 patients, and it failed. ESWD failed when compared to placebo, and there are not much more systemic reviews available on PubMeds. So it is again a controversial, and again the ESWT machine is much more costlier compared to your ultrasound machine. So we may use ultrasound machine as a first line of treatment compared to ESW. Moving on towards laser, yes, laser therapy has evidence in supporting, especially with 904 nanometers of wavelength. 904 nanometers of wavelength. It gives short-term pain relief and reduces disability. Okay. Orthotics generally made up of neoprene, and again controversial. Cochrane review says there are limited number of trials, and the outcome numbers measures are again also some people have just done on pain. They have not focused on functional capacity. So we need to focus much more on orthotics. Tennis elbow brace is generally prescribed and it is advocated. And yes, it helps the patient to reduce pain and reduce the activity. Yes, and gives adequate time for healing. So orthotics, acupuncture, I am not much more fond of promoting this pseudoscience. Again, sorry, many people would not like my this statement, but lack of evidence forces me to say this. No evidence of acupuncture, especially with lateral epicondylgia, is considered. Fink et al. Found that reduction in pain compared to placebo only occurred in early after treatment, but there was no difference after 2 months. So again, it acts like a placebo treatment. Okay, because our goal is not to reduce pain temporarily. Our goal is to avoid recurrence. Yes. So acupuncture is not much more adequate. PRP injections, yes, platelet-rich plasma injections. Platelets are generally taken from the patient's own blood, and they are rich with mesenchymal cells and type 1 collagen and collagen fibers. As I said in our first few slides, that collagen is much more necessary, and PRP have shown, yes, have shown uh, results. Okay, but large number of trials and reviews are still pending, but this is a ray of hope. This is definitely a ray of hope for long-standing chronic elbow cases. Hyaluron gel injections and botulinum toxins. Yes, more used in arthritis and tendon healing. Yes, limited studies are available. Why tendon arthritis? Because cartilage and tendon. Okay, cartilage and tendon, they have similar properties when it comes to healing. So that is why this kinds of injections and botulinum toxins are used. One more disadvantage with botulinum toxin is that you need to immobilize your fingers, and then it leads to stiffness of these fingers when we remobilize. So it is generally not advocated. Uh, Surgery, yes, definitely. When in chronic cases, when all the conservative treatments have failed, uh, somewhere around 4 to 11% of patients, it is a huge number. If we term it out, about 4 to 11% of patients undergo surgery, because chronic pain is so disabling. It creates so much of stress, and especially when I term it out about an athlete, as I said, athlete needs to go back to the field. Yes, so surgery, it is definitely, but again, rehab is necessary post surgery. So as much as we can conservatively treat the condition, surgery should be avoided. And what kind of surgeries are there? Extensor releases, V by slide, denervation surgeries, and garden procedures. Again, this is an orthopedic topic. I would not like to. I can show the surgeries later on. So minimal invasive surgeries are also into the and they are having good evidence. Yes. Yes. What is the activity modifications? What can we do, especially with the tennis players, racket hands players? Uh, how can we select an appropriate racket? So it is based on your measurement. So what does this initial technique says? To proper handle the size from proximal palmar crease. Okay, so this is your proximal palmar crease and the ring crease of the top between your ring finger and middle finger. So this should be the measurement of your racket grip. Okay, so this is the measurement of your racket grip. Lesser than this and larger, longer than this will lead to your improper force distribution, and it will lead to tennis elbow or lateral epicondylgia. So here you can clearly see initial. Yes. So size is measured from proximal palmar crease to these crease, middle and ring finger, and the measurement is obtained for proper handle size. That is, if the distance is 4.5 inches, the proper size handle should be 4.5 inches. So for example, this is 4.5, you should take 4.5. It is 5 inches, you are supposed to take 5 inches. If it is 3 inches, you are supposed to take 3 inches. So this is where we can modify, and strings can be used, racket strings. So what are we coming to a conclusion? Yes, it is a very challenging condition. Yes, theoretically, and if you have not seen much more patient, you see just, oh yes, it is just lateral epicondylitis. It happens to many people. But if the patient goes into a chronic stage, mark my words, it becomes very difficult to come back. It becomes very difficult to come back through conservative management, and it is our challenging procedure. Okay, so various non-surgical modalities are being used based on the expertise, and you can have activity modifications. And first line of treatment should always be conservative management, not the surgery. And the treatment can begin with physiotherapy, manual therapy, braces, okay, and oral or topical NSAIDs. Okay, I would recommend topical NSAIDs first rather than oral NSAIDs. Steroid injections are not at all recommended because of high recurrence and relapse rate. Okay, when we are failing with our conservative approaches, we have a ray of hope with our PRP injections, platelet rich plasma injections, and then ultimately surgery. Okay, so what should be the line of management? First thing, physiotherapy conservatively. And in physiotherapy, what are we going to do? stretching strengthening exercises, ultrasound, your soft tissue release techniques like MFR, MET. You may try with malignant mobilizations, and if ultrasound fails, you may jump to laser therapy. These are what I would recommend you. If we are failing in this, yes, we may go to PRP injections, and later on with PRP is also failing, surgery is required. Okay. So thank you very much for listening me. Uh, I would like to share you one more video also uh, with this. Just wait a minute. Okay. Yes. So the video which I am going to share is the EMG biofeedback video, which I have uh, adopted in my therapeutic procedure. Uh, you will see this later on. We'll discuss what we are doing. So these two electrodes are surface electrodes. Yes, we are being using it with. We are basically what we'll do. We'll first find it out the action potential of larger group of muscles. The only disadvantage with this is, as these are surface electrodes, the accurate muscle is not being identified, because ECRV is much more into depth. Victoradialis covers that muscle, but needle electrodes are used. We can use needle electrodes just to avoid base our day-to-day practices of needle electrodes. I've used surface electrodes. So let us see. See. So here you can see this is the bar graph. So this is what one channel is activated. This green is nothing but channel 2. And why the voltage is being seen, it is because of the artifacts. So once the patient is doing the activity of this tech sensor, you can see this bar graph extending, and you can see 41 microvolts being connected. I think my video is hanging. Yes. So what I'm doing is I'm giving a biofeedback game. This machine has a peculiar feature of bunny games, playing games, and giving roses. I don't want it. I didn't want my to give rose to my patient, so I'm giving a bunny to the patient. I think my system is hanging a bit, so you cannot see a proper video.
Yes, sir. It is stopped with that finger.
Yes. just giving you what we do is after bunny game. Yes, I hope this works it out. So once the patient is doing work like wrist extensions, which you are doing it, the bunny will go up the hill and you will catch the carrot. So here you can see I've set up the two limits at 71 microwatts and 70 microwatts. Yes. So once you cross that 70 microwatts limit, then and then only the bunny will start moving it. And in the rest, you are not supposed to do anything. Okay, so I think it is hanging. I will stop sharing this device. Yes. Okay, so I've done with my presentations. I hope you all enjoyed it. We have crossed somewhere around 20-30 minutes with the
No
presentation.
problem. Really, it is a very nice presentation. We
Thank
can
you.
take questions now.
Yes, yes.
Can I read it out? Yes, sir.
Definitely, definitely.
Yes, sir. The first question is from Mr. Panduranga Rao. Sir, as
Yes.
muscles are becoming weak, so there may be chances of muscle knots or bands to be formed. So it can be treated with dry needling.
I said acupuncture. Dry needling is the brother or sister of that acupuncture, and I usually don't recommend it because of lack of evidence. So there are people who say that it is effective, but evidence says there is no. It is just like a placebo. So we should reframe. We should not touch that area also.
Fine, sir. In between, we have many appreciations and credits for your presentation, sir.
Thank you. Thank you.
Next question is from Ms. Anisha Singh. Sir, can you differentiate medial epicondylitis and lateral epicondylitis in short?
Anita Singh, I just had, okay, for you, I will say medial, you have two epicondyles. One is the medial epicondyle and another is lateral epicondyle. On to the medial epicondyle, we have flexor group of muscles, common flexor group of muscles origin. And on to the lateral group of muscle, lateral, we have common extensor group of muscles. So whenever these medial group of muscles are being involved, it is medial epicondylitis. Why I am saying it medial epicondylitis? I again say that there are lack of evidences or lack of studies which say that there is no inflammation in medial group of muscles. Okay, so there are studies which say that in lateral epicondyle regions and lateral common extensor group of muscles, it is not inflammatory markers are not available. It is tendinosis which is taking place. Okay, so medial epicondylitis, common flexor group of muscles, and it is known as commonly it is known as golfer's elbow, and commonly it is known as lateral epicondyle. It is known as tennis elbow.
Fine, sir. Next question is from Mr. Mohan Rasu. Patient affected posterolateral elbow dislocation treated on closed reduction elbow using with a 3 weeks immobilization. After removing sling, patient complained pain in lateral epicondyle and posterior elbow. Any suggestions, sir?
A very long question.
After
The question
immobilization
is that,
of 3 weeks, he is having pain in his elbow.
So pain in the elbow will not be related to this condition. It would be much more related to your immobilization. Yes. So the best way is to go for muscle energy technique, post isometric relaxation, and then increase the range of muscle, range of the joint, and later on you need to focus it on our pain relief modalities like IFT or TENS, which would work it out for that patient.
Yes, sir. Next one is from Miss Anisha. Sir, muscle stimulator can be used in lateral epicondylitis?
No. I don't recommend muscle stimulators for using it, and because muscle stimulators are basically, you can use neuromuscular electrical stimulations NMES, or why, because the video which we had seen recently, the EMG biofeedback video, that muscle NMES, what does that do? It stimulates the muscle, and then you ask the patient to contract. So after every stimulation, the strength of the muscle will increase. Yes, so that is, you can use neuromuscular electrical stimulation rather than your galvanic stimulation or your Faraday stimulations or search Faraday stimulations, because your nerve is not getting involved. You don't have nerve injuries. You have your muscle injuries which is taking place.
Yes, sir. Next one is from Ms. Rutwa. Sir, if patient have cervical pain along with elbow pain, what should be the treatment?
Okay. Cervical pain with elbow pain, as I said in our differential diagnosis, we first need to check it out whether it is the cervical radiculopathy or myopathy which has been affected. First thing, if the cervical pain is there, we need to definitely treat that. And if you find that with your Cosen's test or Mills test, your lateral epicondyle pain is also there. So there are two basic conditions which are clubbed into patient. So you need to treat your cervical pain also through your what we say cervical treatments like your traction or your IFT and your isometric neck exercises and your McKenzie techniques. And then you also need to treat your lateral epicondyle.
Yes, sir. One more question from our YouTube subscriber. Explain isotonic contraction once again, sir.
Isotonic contraction. So isotonic contractions are basically the tone of the muscle is not increasing. Yes. So in tone of the muscles, if not increasing, what is increasing? The length of the muscle is increasing. Isometric means the length of the muscle is not increasing. Okay. And isokinetic means your force of the muscle contraction remains same. Okay. So in isotonic contractions, you have, if I can have an access to the whiteboard, I'll explain it over here itself. So just for an example, the black line over this is your origin and pink line over this is your insertion. Okay. So if this is your red line is basically the muscle acting. So in isotonic action, this is your insertion. So if this is moving towards your origin, this is your concentric group of muscle acting, and moving it ahead from this insertion, yes, to this is your eccentric. Bear with my handwritings and bear with my presentations, but this is what happens. Yes, so isotonic, your tone of the muscle is not increasing, your length of the muscle changes. Yes.
Yes, sir. Fine. The next question is from Mr. Jitender. How does Botox help in LE?
Yes. So Botox, basically botulinum toxin has effects in pain reductions as per the studies which have been shared. I would like to share that study also if it is handy with me. Yes. It is there. Just wait a minute.
Yes, sir.
Yes. So I can share it with you all so that. See, hyaluronic gel injections and botulinum toxins. Yes. So here it is written that for Botox, okay, botulinum toxin into the extensor digitorum longus muscle is given. Okay, annotation. Yes. Botulinum toxin in extensor digitorum muscle is given, and it basically third and fourth fingers paralyzes the muscle and cannot do the extensor tendon and help the patient to recover from LE. So basically, it helps in reduction in the pain and getting the movement reduction to be done. So immobilizing component is used in Botox, but it is highly still in prima phases. So it is highly discouraged currently because there are not much more significant evidence available for this.
Fine, sir. Next question is from Dr. Vinish Kumar. Difference between lateral epicondylalgia and myositis ossificans. How to diagnose it?
Myositis ossification is because of your ossification formation into the muscles. Yes. So it is generally done post immobilizations. And epicondylgia, it is a tendon healing procedure. Yes. So if the tendon is not healed properly, you have fibroblasts coming into picture, miniature bones formation, decreased vascularization, neovascularization. Whereas myositis ossification is totally a different condition, which is based on the miniature bone formations or because of immobilization.
Fine. The next one is from again Mr. Jitender. Sir, how can we improve supination in an old RTA case, 1 year old? That is, when pronation is 0 to 80 and supination is 0.
Supination in old case,
RTA.
Road traffic accident case.
Yes,
You
sir.
first need to see whether joint play movements of your distal radioulnar joints and proximal radioulnar joints. And based on that joint play motion, you please select the glides. I personally, in chronic cases, if I say Maitland glides are much more effective compared to your Calton-Bond or Mulligan techniques.
Fine. The next one is from Miss Nikita. Thank you, sir, for your presentation. Sorry, many more appreciations again in between. Yes, sir. Next one is from Mr. Rajesh Kumar. Patient was chronic pain in elbow, that is lateral epicondyle region. Patient does not do ADL activity. Rajesh Kumar, I'll unmute you. You can
Yes.
ask your question.
Meanwhile, I'll request the organizers, please, if you can share, click the pictures of this.
Hello, sir.
Okay.
Hello, sir.
Yes, we have taken some pictures. Don't worry.
Hello, sir.
Yes, yes.
Sir, patient was elbow in lateral epicondyle injured. Is sudden accident injury. Is chronic pain in last 5 months.
You can explain the question in your regional language also, so that these people, the organizers, will explain you in language which I understand.
You know Tamil?
Rajesh Kumar, Tamil தெரிஞ்சா தமிழ்ல பேசலாம்.
ஓகே சார். சார் எல்போல லேட்டரல் எபிகாண்டல்ல அவருக்கு சடனா ஆக்சிடென்ட் ஆயிடுச்சு, பைக் ஆக்சிடென்ட். ஹலோ,
சொல்லுங்க கேக்குது.
பைக் ஆக்சிடென்ட்ல கீழே விழுந்தாரு, எல்போ ஃபுல் சப்போர்ட்ல கீழே விழுந்தபோது அவருக்கு பெயின் இருக்குன்ற, ஆனா ஃப்ராக்சர் எதுவுமே கிடையாது, நார்மலா இருக்குது, எக்ஸ்ரேல நார்மல், ஆனா அவருக்கு பெயின் மட்டும் இருக்குதுன்றாரு.
Okay, sir, a client with RTA who fell from his bike has fallen on his elbow and his investigation shows everything as negative, but only there is pain in his elbow region. So what management can be done?
What is the duration?
Immediate, sir. Just now he is coming after an RTA.
5 months.
Acute.
5 months.
Acute.
So please see there whether any bursa is involved or not. Yes. Has he underwent with any ultrasonography of the elbow or MRI?
He said only X-ray, sir. He had undergone with X-ray. There are no fractures,
So with
but soft
X-rays we
tissues.
just come to, yes. X-rays which just will come to know about the bones. Yes, we won't be getting a clear picture idea about the bursa or the ligaments, and it is what we say a traumatic injury. Yes, not basically a non-traumatic injury. So we may suspect a contusion injury or a bursa which has been inflamed, like you may have a student's elbow, any kind of that.
Fine, sir. Next question is from Mr. Ravi Prakash. In advanced case, people show symptoms like pain while doing wrist flexion also?
Yes, because of eccentric group of muscle. Yes, so that is what I said, that in the backhand stroke also, what the role of extensor group of muscle is to extend the wrist. Yes, but once the ball which hits the racket, what it will do, it will give a counter force, and immediately after extension we are supposed to do it wrist flexion. wrist flexion is because the eccentric exercises, eccentric group of component which is acting on your ECRB. That is the reason why it gets pain in wrist flexion also, and that is what your Mills test do. Okay.
Yes, sir. No more questions. Dear participants, you have any questions? Yeah, one more has raised. Sir, is there any need of investigation like X-ray for tennis elbow?
No, dear, not at all. We luckily our special tests are much more reliable and valid for this condition. If you have if you are performing an accurate test in an accurate manner, your Cosen's test, Mills test, and Motley's test are more than sufficient to diagnose lateral epicondylgia. Okay.
Fine, sir. We'll conclude the session. Before concluding, I'll ask our volunteer Prachi Buch to take over and conclude the session, sir. Prachi Buch, are you there?
Yes, sir.
Yeah.
Hello. It was a very informative session, sir. Hello.
Yes, yes.
Yes.
I can hear you.
Yes. Is everyone able to hear me?
Yeah, yeah.
Yeah. It was a very informative session, sir. Thank you for speaking about this topic. Lateral epicondylgia is not very frequently discussed, and you explained everything, starting from basic anatomy to pathophysiology, the 3 special tests, the outcome measures, all the outcome measures, the treatment, evidence-based treatment programs in very detail. I'm sure all the participants must have gained a lot of knowledge from the presentation. Thank you for solving doubts of participants enthusiastically and patiently. We appreciate you making time in your busy schedule on Sunday. Once again, thank you, Dr. Parth Trivedi, sir, the organizing team, Exrx India team, and all the participants. It wouldn't have been possible without all of your support. Thank you again. Thank you so much.
Yes, sir. Thank you very much, sir, for the wonderful explanation, even about the researchers. So that only have boosted this session, especially, sir. So it would have been success without any research.
Yes.
This research has given the main importance on your session, sir. Thank you very much for it.
To all the presenters, and even I think we are going on live with the YouTube also.
Yes, sir.
To all those who are listening, the trend of what we say giving treatments without evidence is now need to be changed. Yes, especially post-COVID era. If it was not like that, then we would have treatments for COVID-19 also. Yes. So till this date, we are not finding out an optimum treatment for COVID-19. This itself says that we need to have an evidence in treating whatsoever we are having. So without evidence, please, if somebody is, saying that, if I am saying that, an X thing which I am giving is much more effective compared to a Y thing which is already there, please just don't blindly believe this. Okay. Please ask for evidence, and evidences like case reports, definitely if you term it about research, even an expert like me, if I say that, tying your lateral elbow with a towel will reduce your pain, that is an expert opinion. Okay. So you may believe, you may not believe. Then it goes to a case study reports. After case study report, it goes to your RCTs. And after RCTs, it goes to your systemic analysis, systemic reviews. So if any treatment which has systemic reviews in positive favor, definitely that is a valid treatment. So please focus it on. And I request all the budding and young therapists and even the clinicians, please try to focus on the evidence treatment approach now, because it was being taught and it was being practiced in Western countries somewhere around 15 to 20 years back. Yes, and we are still lacking in that. So we need to move on with this. Thank you.
Thank you, sir. I hope we can have one more session clearly on evidence-based physiotherapy, sir, in future.
Thank you. Thank you.
Sure, sir.
Thank you, Parth Trivedi. I was having a little net issues and power issues.
You did very well. Thank you so much.
Thank you. Thank you.
Yeah.
Thank you, sir.
Thank you.
Bye bye all. Good night.
Thank you. Bye bye. Thank you.